Good day and welcome. We're here at the ESMO meeting 2025 in Berlin, Germany. And my name is Mark Pegram. I'm a medical oncologist from Stanford University in Palo Alto, California. And I'm pleased to be joined tonight by Dr. Neil Iyengar.
Thank you. Yes, it's a pleasure to join you, Dr. Pegram. So my name is Neil Iyengar. I'm a medical oncologist, subspecialized in breast cancer therapy. I'm the co-director of breast medical oncology and director of cancer survivorship services at the Winship Cancer Institute of Emory University in Atlanta, Georgia.
Fantastic. It's always a pleasure to get to work with you again, so
Likewise.
Thanks for doing this. We've had the opportunity to work together many times, and
Yes.
It's always been a great fun and great opportunity for me, so Thanks for being here. Tonight I thought we'd talk about HER2-positive disease for a little bit. And in particular, I want to talk about early breast cancer first, because there are a lot of highlights at this meeting in that area. But also first-line metastatic disease, which has a lot of new data sets to consider as well, some controversial in some ways. And then at the end, if we have time, we'll just touch a little bit on HER2-low and ultra-low to wrap up. So first, let's talk about the exciting data at this ESMO on neoadjuvant therapy of HER2-positive disease, in particular the DESTINY-Breast11 neoadjuvant clinical trial. Can you just tell us a little about the study design, the randomization, et cetera?
Absolutely. So I would start off by saying practice-changing data and really, really exciting data. So let's talk about the trial design. DESTINY-Breast11, as you mentioned, is a neoadjuvant study that really asked the question of whether we can replace anthracycline with Trastuzumab Deruxtecan for high-risk HER2-amplified breast cancer, primary breast cancer. And so the trial randomized patients to receive dose-dense AC followed by THP or Trastuzumab Deruxtecan followed by THP with a primary endpoint of pathologic complete response. The trial was a multi-center phase 3 trial that was conducted globally. And ultimately, the patient population, I would say, is quite representative of what we see in clinic. In terms of the primary endpoint, pathologic complete response, there was a delta benefit of 11% favoring the Trastuzumab Deruxtecan followed by THP arm versus AC-THP. I would call this a clinically meaningful advance in pathologic complete response rate. That is why I started by saying I think this is practice-changing data. But I'm sure we'll talk a little bit about the adverse effect profile and so forth, because, of course, there are considerations as we think about applying this to our patient population.
Now, what about the control arm? You know, it had an anthracycline. Is that the right choice of the control arm, do you think? Or could it have just been TCHP?
Yes, well, as you know, I've trained on the East Coast, and part of our East Coast, West Coast discussions, which I'll inform the viewers, have been anthracycline versus non-anthracycline containing regimens. So I would say that we have certainly moved away from anthracyclines in the HER2-positive setting, and I think that's largely because of advancement in what's available for residual disease and better HER2-targeted therapies. However, that being said, this trial, TB11, was designed for a high-risk population.
Exactly.
And we say what you will about anthracyclines, but they are effective and particularly effective for our high-risk patients. And this trial was designed to address that high-risk population. I think it was completely appropriate to have an anthracycline-containing regimen in the control arm.
It was a particularly high-risk group, I understand. Many of them had inoperable disease at diagnosis.
Yes.
Or operable plus node-positive disease as part of the
yes.
eligibility. So it was a kind of higher than average risk group, perhaps, in that regard.
Absolutely.
Now, ACTH compared to TCHP has been studied in the TRAIN-2 study, and that showed no difference in PCR.
Right.
So in terms of the efficacy delta, I don't think it probably matters what the control arm was, except as regards toxicity. We'll talk about that in just a little bit.
Right.
Now, do you think this magnitude of the change in PCR, is 11% enough? Is that a clinically meaningful amount, do you think?
It's a good question, and of course, we await maturity of the event-free survival data. But that being said, we have not been in this situation before. We've looked at PCR as a surrogate of longer-term endpoints in HER2-amplified disease, and I would say it's very encouraging. I think that we certainly need longer-term follow-up data. This is the initial look. But I would be, if I was a gambling person, I would say that I would be hard-pressed to say that this is not going to translate to a long-term benefit with an 11% increase in pathologic complete response rate.
And the interim event-free survival that was shown here at ESMO, I mean, it certainly had a trend favoring the experimental arm.
That's right. That's a very good point, too. I mean, it was an early look at immature data.
Very immature.
But that being said, the longer-term survival data looked very promising already.
Now, the other exciting thing to me about DESTINY-Breast11 is the fact that it's just 4 cycles of T-DXd. Is that an opportunity with this increase in PCR? Because the PCR patients don't need an ADC in the adjuvant setting in particular. So is this an opportunity for de-escalation if we can increase that PCR rate and then not have to worry about TDM1 or T-DXd we'll talk about next in the DB05 trial? But what are your thoughts on that?
Yeah, I think that's such an...
Those are 14-cycle regimens.
Right.
Both of them.
Yeah, this is an incredibly important point here. Certainly, I view this as when you improve the PCR rate, not only do you have the potential of improving the long-term outcomes, but you also have the potential of saving the patient from added toxicity in the adjuvant setting, in the residual disease setting, because you're reducing residual disease. So I think that this is an added potential plus of the study. You know, you also mentioned, and I wanted to sort of come back to this, but go back to the anthracycline taxane debate. You know, in TRAIN 2, there was a lot of taxane, and so to loop back to your point about 4 cycles of T-DXd. You know, I think that if we're thinking about using a TCHP regimen as the alternative, we have to really use quite a few cycles of TCHP.
And that's a difficult regimen for many patients.
Yes, absolutely. Yeah. So I think, as you have alluded to, I think the limited cycles, the 4 cycles of T-DXd is another benefit of this regimen.
Now, Neil, let's talk about safety signals of specific interest for T-DXd, in particular ILD. What did that data look like in DESTINY-Breast11 in the experimental and the control arms? And in particular, were there any grade 5 events in each arm?
Yeah, important question. Certainly in the curative setting, we're watching this very closely. And I was very reassured to see that the overall rate of ILD certainly was not higher than what we see in the metastatic setting. In fact, it was a little lower. And in terms, to address your question with regard to grade 5 events or death related to ILD, there was 1 death related to ILD in the T-DXd arm, and there was also 1 death in the control arm as well.
I see, so kind of offsetting in that regard, not an imbalance at least.
Right.
Interesting. Now, another adverse event of special interest is cardiac adverse events, and there were more in the anthracycline arm.
Yes, yeah, I mean, I would say anticipated, but yes, there were more cardiac events in the anthracycline arm, getting back to that point of why, now that we have this data, and pending approval, of course, why leave patients at that long-term risk of anthracycline-related cardiotoxicity when we don't see that with T-DXd?
So what's your final take on DB11, or anything else you want to bring out about the presentation or the discussion?
Well, I think that DB11 certainly sets the stage for a new standard of care for our patients with high-risk, locally advanced HER2-amplified breast cancer. I'm very encouraged by that 11% increase in pathologic complete response rates, but of course we do have to wait for data maturation for the longer-term EFS rate, but it's very promising already at the immature look. One caveat I will say, though, is, as we will talk about, is we have also seen data for T-DXd in the adjuvant residual disease setting, and so one of the things that we are going to have to grapple with is what do we do now with data in the neoadjuvant setting and the adjuvant setting as well?
Great question. That leads perfectly into our next segment about DESTINY-Breast05, which is a head-to-head comparison of 14 cycles of T-DXd versus 14 cycles of TDM1 in the adjuvant setting for residual disease following neoadjuvant therapy. What were the top-line data for that trial?
Right. So in this trial in DESTINY-Breast05, patients, again, were high risk. So these were patients who were essentially node positive at baseline pre-surgically, or node positive in the setting of residual disease at the time of surgery. And patients were randomized, as you said, to receive Trastuzumab Deruxtecan or TDM1 per the prior Catherine trial. And here what we found was that patients who were randomized to receive Trastuzumab Deruxtecan had a significant improvement, both in terms of their recurrence risk, but of course in terms of recurrence-free survival. And in the high-risk residual disease setting, I think this is extremely important because, of course, we know that despite the advances with T-DM1 and Catherine, we still have patients who recur and become metastatic. The other big question, of course, is CNS disease as the site of recurrence, and I think we were watching this closely as well, since we have seen data in the metastatic setting indicating the CNS activity of Trastuzumab Deruxtecan, and we did indeed see fewer CNS relapses as the first site of metastatic disease in the T-DXd arm.
Numerically fewer.
Numerically fewer,
Yep.
yes.
Interesting. Now, what about the safety signals in this trial? How many cycles can patients tolerate for these two ADCs?
Yeah, I think that is the question. So this was 14 cycles, and
It's a lot.
It is a lot, and we know that T-DXd has adverse effects that can be managed, but in the adjuvant setting, we do need to make sure that we're managing AEs like nausea and fatigue and so forth. I think in the curative setting, though, there is a different risk to benefit analysis here because, again, we're really going for cure. And if we can improve the recurrence rate and the recurrence-free survival rate, I would say that the ratio of clinical benefit here in terms of improved efficacy using T-DXd versus the AE profile does still, in my mind, favor using T-DXd in the residual disease setting.
I see. Okay. And what about adverse events of special interest in DB05, in particular ILD? What did that look like?
So again, ILD in the curative setting is something we watch very closely. These patients were monitored with CT scans for pulmonary changes. And again, we saw an ILD rate that overall was consistent or actually a little lower than in the metastatic setting. So in terms of grade 5 ILD events, there were 2 ILD-related deaths in the T-DXd arm and 1 in the T-DM1 arm. So again, we don't see an imbalance there, and small numbers as well. But screening for ILD is going to be important in the.
How should we do that?
In the trial, it was CT scans every 6 weeks, and this is something that we do need to make sure that we're doing, particularly in the adjuvant setting or in the curative setting.
You're going to do the same as on the protocol?
Yes.
Okay, that's very important. Good. Any other safety concerns to note between the two agents?
I think we've become familiar with managing the safety profile of T-DXd in the metastatic setting, and I would say that there were no new signals of concern in the neoadjuvant or the adjuvant setting, and so this is a manageable approach as long as we are, of course, screening for ILD.
Now, if somebody, let's say, gets neoadjuvant T-DXd, according to DB11, but has residual disease, are you going to give them T-DM1 or are you going to give them more T-DXd?
This is a great question. So I think that with the release of both data sets at once, this is the situation that we're in now. If we're using T-DXd in the neoadjuvant setting, what do we do for residual disease in the adjuvant setting? I think the way that I view this is that there are certainly questions here, and one is that is the residual disease an artifact of needing more exposure to T-DXd? Is it due to resistance? So I think some factors will come into play in that decision in terms of how much residual disease are we dealing with, what type of treatment response did we see. I think in the setting where I suspect that we're dealing with resistance, if it's a suboptimal response, which wasn't the case in the majority of patients in the trial, but if that is the situation, then I would think about using a different agent.
Right.
But I suspect, based on what we saw in the trial, the response rates and so forth, in both trials, that it might be a matter of needing more exposure to T-DXd. And so we do have the option of continuing T-DXd pending approval, of course, in the residual disease setting, even if we've used it in the neoadjuvant setting as well. Indeed,
the residual cancer burden scores in the trial, RCB, the 0-1s were like over 80% in the T-DXd. That's the highest I've ever seen.
It was really quite remarkable.
And I believe this trial, the DB11 trial like sets a record on that front,
Yes.
doesn't it?
Yeah,
It's
absolutely.
amazing. Yeah. Good. So you think both of these potentially are practice changing?
I think so, yes. I think this is, the data are encouraging, and as we've been discussing, the AE profile is also encouraging. And this is a high-risk population, and so we really need to advance our treatment approach and our cure rates in the primary setting, and T-DXd has done that in these trials.
Fantastic. Let's move to first-line metastatic. There's been a lot happening since San Antonio in that space. So at this meeting and previously, I believe at ASCO, we saw the DESTINY-Breast09 data, which for the first time threatened the reign of Cleopatra. Tell us about that.
Yes. Well, we certainly have had Cleopatra in the first-line setting for quite some time. We've seen
More than a decade.
Yeah, and we've seen long-term follow-up data. I mean, I remember learning from you about management of metastatic HER2 amplified disease, and just to see how quickly the landscape has changed in recent years is really remarkable. And so with long-term follow-up data of Cleopatra, we certainly have seen an overall survival benefit and so forth. But we also know that there's certainly room for improvement, and that there are specific toxicities associated with taxane, neuropathy, and so forth. And so I think the question of whether or not T-DXd is an appropriate and effective option in the frontline setting is really quite relevant, both from the perspective of improving efficacy, but also from the perspective of potentially shifting the toxicity profile to be more manageable.
Sure.
So certainly in DESTINY-Breast09, that essentially is what we did see. This was a frontline study comparing Cleopatra to T-DXd. And we saw a significant improvement in progression-free survival in patients who were randomized to the T-DXd arm versus the Cleopatra arm. And as you said, this really represents the first data set demonstrating a significant improvement over the taxane HP regimen.
Now, it was actually T-DXd plus pertuzumab, and then there was a third arm of T-DXd alone, which has not yet been reported.
Yes, thank you for clarifying. I should mention that we saw data for the combination of T-DXd plus pertuzumab. You know, I think we're awaiting that T-DXd monotherapy data, but certainly T-DXd
is to be reported in the the final data suite for the IDFS endpoint.
Yes.
I understand, or I'm sorry, PFS endpoint, primary endpoint.
Yeah.
When that becomes mature.
Yeah.
Well, that's great. What about safety signals of special interest in DB09?
So I think, again, we did not see any new signals of concern in the frontline setting. The ILD rate was consistent with what we see in later lines of therapy.
There were a couple of grade 5s.
A couple of grade 5s, yes, but we've, of course, seen that in later lines of therapy as well. But it does highlight, I think it's important that you point that out, because it does highlight, even in the metastatic setting, the need to screen for ILD as well.
Right. Any lessons learned from any of the subgroup analysis in DB09?
So here at ESMO, we did see an updated presentation with regard to the subgroups, and I think the take-home message, at least for me, was that we see consistent activity or consistent benefit across all of the subgroups that were analyzed, genomic subgroups, global subgroups as well. And I think this is encouraging because, again, when we're thinking about potential subgroups that drove the benefit, we really see that it was generalized across all of the patients that were enrolled.
Yeah. Great. Now, this data set comes kind of on the heels of the San Antonio meeting last year, where the Patina trial was first shown as a late-breaking abstract, indeed. And in this strategy, patients who were given a induction, if you will, of taxane with HP, the Cleopatra-like induction, in the ER positive, hormone receptor positive subgroup, they were then given a continuation of the dual antibodies with an anti-estrogen, with or without a CDK4/6 inhibitor. What was the scientific rationale behind addition of CDK4/6 in the HER2 positive, hormone receptor positive space?
Yeah, great question. So the Patina trial was really quite interesting, and in terms of the rationale for combining both endocrine therapy and CDK4/6 inhibition with HER2-directed therapy, we certainly know that there is crosstalk between the ER-regulated pathways as well as HER2, which also includes crosstalk with cell cycle. And so there is a biologic rationale for combining CDK4/6 inhibition with endocrine therapy and HER2-directed therapy. certainly under the Cleopatra paradigm, that maintenance period during the antibody alone therapy is an area where we've been looking to find interventions that extend that maintenance or chemotherapy-free interval. And Patina was very exciting by showing essentially a 44-month median progression-free survival. Incredible with CDK4/6 inhibition and dual anti-HER2 therapy. Now, I think you mentioned a very important point with regard to Cleopatra being sort of the induction regimen, if you will. And I think what I took away from this trial is that once you're able to induce a favorable response, because, of course, remember, this was a requirement of the trial. Right. Once you're able to do that, then adding endocrine therapy and a CDK4/6 inhibitor in that maintenance setting is a successful strategy for prolonging that time.
And even the control arm in that trial did quite well.
Good point.
And
yes.
I think that's because some patients didn't finish the induction because of disease progression. If you look at the stair steps on the original Cleopatra and Kaplan-Meier analysis, you'll see that you lose a few to several percent off the top due to disease progression, even with the THP induction. And I think once those are subtracted out, because the randomization occurred after the induction was over. So yes. It's important for our listeners to know not to compare Kaplan-Meier plots of DB09 head-to-head with Patina, because they're completely different patient populations where the randomization occurred at completely different times.
Yes.
So don't fall into that trap.
That's such an important point, right? And I think we've all had those patients who unfortunately either progress or they don't have the response we're looking for during that induction taxane phase of Cleopatra. And as you importantly point out, they were excluded from Patina.
Right. Now, why don't we just do T-DXd plus P as the induction and then do Patina for the hormone receptor positive subset, do the Patina regimen for maintenance?
That's a good question. So the trials, of course, Patina was not designed in that way. They did, of course, enroll patients who received Cleopatra induction. And so we don't yet have a trial that has been that has reported T-DXd induction followed by an endocrine CDK4/6 inhibitor Patina type approach. However, that being said, I think that we, of course, need to think about the principles behind these studies. And as you mentioned, patients were randomized on Patina after they had a favorable response to induction therapy. So I would argue that we really want to use a regimen that has the highest likelihood of inducing a favorable response that we would then want to maintain. So for me, these are separate topics, right? The question of how do we induce the best response, and then the question of how do we prolong the maintenance period.
I see.
And so if I think about that separately, we have data from DESTINY-Breast09 indicating that T-DXd plus pertuzumab is superior to Cleopatra in terms of progression-free survival.
Yes.
So potentially I could envision using an approach where we induce with T-DXd pertuzumab, and if they're hormone receptor positive in addition to HER2 amplified, we then switch to potential maintenance period, which is a la Patina, but with the major caveat that this is extrapolating from the two trials.
It's interesting, Neil. I was just at a meeting in San Diego about a month ago, and there was an audience response polling question with a group of practicing oncologists in the audience, pretty large group actually. And this question came up, would you consider doing a T-DXd plus P induction followed by a Patina maintenance? And 85% of the audience said yes. And I said, are you sure in the absence of no data whatsoever, you're willing to do that? They said, we don't need data to extrapolate. They were very secure. And
that's remarkable.
That's what they're planning to do already.
Yeah, I mean,
hopefully we'll get some data to back it up.
I hope so too. Yeah. But it makes sense, right? It makes sense that we really need to maintain a disease state where we've already minimized the disease, and those response rates with T-DXd, of course, are superior. And so I think
record setting once again.
Right.
Amazing.
Yeah.
In the last segment, let's just talk a little bit about HER2-low and ultra-low in HER2-negative hormone receptor positive advanced breast cancer. There was a clinical trial called DESTINY-Breast06. Can you tell us a little bit about that design and top-line data?
Yes, so DESTINY-Breast06, as you mentioned, enrolled patients with not HER2 amplified disease, but low expression of HER2. So this was essentially defined as a IHC of 1+ or 2+ and not amplified by FISH. The trial also enrolled patients with a new terminology, ultra-low. And HER2 ultra-low, of course, are those patients who may have been previously classified as IHC 0,
right.
But you see interspersed membranous staining essentially. And what was interesting about the trial, it also sort of moved up T-DXd a little in terms of lines of prior therapy. So really addressing the question, should we be thinking about using T-DXd right after endocrine therapy resistance?
I see.
And then can we also include our ultra-low patients?
So as a first foray into kind of cytotoxic,
Yes.
instead of chemo,
Yes.
because that was a control arm.
That's right.
Chemo du jour,
That's
so to
right.
speak.
This was a randomized phase 3 trial with the standard of care arm being chemotherapy.
And it's a
of physician's
positive
choice.
study.
It is a positive study, so there was a progression-free survival benefit using T-DXd in that population versus physician's choice chemotherapy.
And the ultra-low subset analysis kind of mirrored the intent to treat population as well.
Yeah.
Even though it was a smaller subset analysis, so not robust statistics necessarily for that group, but
Right.
the trend seemed to be the same. And as a result, the FDA has label indications for both low and ultra-low.
That's right. I mean, I think a strength of the study design, as you mentioned, it was the ultra-low subset was a smaller sample size or population, but this was a pre-planned analysis.
Exactly.
And so I think that helps to bolster the results a little bit.
Interesting. Now, do you think this is going to be kind of the logical next step for everyone who becomes endocrine refractory right off the bat? What if somebody has a long natural history? Maybe they've been on anti-estrogen treatments, multiple in a row for years in some cases. Do they need a ADC right off the bat, or couldn't they just take capecitabine for a while and wait and see?
It's a
What do you
fair
think?
question. I mean, I think that ultimately, once a patient's disease becomes endocrine therapy resistant, they're very likely, and their tumor's HER2-low, they're very likely going to get TXD at some point. It's an effective agent in that setting.
Sure.
Now, to your question of should we be using it up front, or perhaps we should sequence a line of chemotherapy beforehand, I look at this as an opportunity to discuss that with the patient.
Sure.
I think that I have certainly treated patients who, in that setting, even if it's indolent, slow-growing disease, are concerned now that they've exhausted endocrine therapy options and really want to pursue the most effective therapy immediately. Whereas other patients do like the oral nature of capecitabine, having just come off typically oral regimens,
right.
and so forth. So it is a discussion. But that being said, I will say I think we've all been in the scenario where you're treating indolent disease, but at some point it starts to progress, maybe not rapidly, but at a faster pace than it was in the endocrine-resistant setting.
Sure.
And so I do still think it's reasonable, even in the low-burden setting and fairly slow-growing setting after endocrine therapy resistance, to consider T-DXd as your first cytotoxic line.
So at least it's an option, and a balanced discussion with the patient would be
Absolutely.
appropriate
Yeah.
in that instance. Very helpful. Any new safety signals? Is T-DXd kind of the same safety as in HER2-positive disease in these HER2-low and ultra-low cases?
It appears to be the case, and I
Okay.
think that, again, that's reassuring when you see consistency in the AE profile like that.
Indeed. That's great. Any final comments about DESTINY-Breast06? Anything else?
Well, I think that the issue that comes up, and given your expertise in HER2 characterization, would love to hear your opinion on this. But I think the question is, how do we systematize reporting for HER2 ultra-low, and should we be looking at new assays for quantification?
It's a tricky question because different agencies have changed the nomenclature even for ultra-low. Some call it 0+. Some call it barely perceptible membrane staining in less than 10% of the cells. So the definitions are kind of the wild, wild west still. But they all essentially mean the same thing, like a little bit of HER2. I don't think that's good enough. I think our patients deserve better. I think they deserve a quantitative number if we think this is an important measure. If there is a true difference between 0 versus ultra-low, then I think we need to measure it and measure it quantitatively. And as you know, there are methods available that can do just that. They just need to be commercialized. But there's really no impediment that I see to making that commercialization happen. It is an important clinical distinction in 2025, and as such, I think those assays should be developed commercially at rapid pace. If we learn later that the IHC zeros have a similar response as the ultra-low, so be it. Those trials are underway, as you know, so we'll get the answer. But I think we need to be prepared for quantitation of low levels of HER2 with precision and reproducibility, and because right now these, the concordance amongst pathologists for low is not good, and ultra-low it's got to be even worse, right?
Yes.
So our patients do deserve better, and I think that's going to be in the works if the ongoing trials now looking at HER2 zero prove to be less impressive than the ultra-lows and lows.
Absolutely.
So we'll see. Well, we've covered a lot of ground today. Breaking news from ESMO 25 on the neoadjuvant front for HER2 positive disease, the adjuvant front also with ADCs battling it out in a head-to-head comparator. First-line metastatic is poised to change from the Cleopatra era to the T-DXd plus P era, and maybe T-DXd era once that third arm becomes mature. And now we have the opportunity for a maintenance phase in the triple positive subset as well. And now, what I can't believe that during my career, we've moved from treating HER2 positive disease with these HER2 targeting agents to treating HER2 negative disease with these HER2 targeting agents, including low, ultra-low, and the likes of these lower level expression. I never thought I would see that. I thought all the things we worked on with antibodies and antibody drug conjugates since the 90s, I thought all this would probably be restricted to HER2 amplified and overexpressing cases and never be useful for low and ultra-low. So it's amazing to me to have the opportunity to see this in one career.
It's phenomenal.
The change in patient population, and it opens up HER2 targeted therapy to something like 85% of breast cancers.
It's remarkable,
That's unbelievable. So this is a new era, indeed.
Absolutely.
Thank you, Neil.
Absolutely.
Always
Thank
a
you.
pleasure.
Pleasure.
Appreciate it.